Hey now, I'm Jack Cush, executive editor of RheumNow.com. It's May the 5th, 2017. This is the RheumNow Week in Review. Today we're going to talk about magnesium. Could it possibly help nocturnal leg cramps? And guess what? There's a new, expensive, and also really cheap way of giving methotrexate to kids. And there's a new drug that's been approved by the FDA called abaloparatide. Get out your pencils, we'll talk about it later. At the top of the news, a Japanese study by Tom Taguchi's group looked at the possibility of either escalating or de-escalating the dosing of IV Actemra in patients who are doing well or not doing well. So if you've achieved a low disease activity state, maybe you could de-escalate. And they changed those patients who had achieved that state at the usual dose, 8 milligrams per kilogram of IV Actemra. They changed them from every 4 weeks to every 5 weeks. And guess what? They did just fine. Likewise, patients who were not doing well, who had not achieved an LDAS, they escalated their frequency from every 4 weeks to every 3 weeks, and guess what? They also proved efficacy. So there's good data to actually support going up or down, and you can reference this in patients who you have to give Actemra in an otherwise dose than Q4 weeks. A study about interstitial lung disease and the risk factors of that looked at a large cohort, found that the risk factors are many that we know, a few that might surprise you: high disease activity, rheumatoid factor and CCP, smoking, especially in those who are HLA-DR beta 1 allele positive. And what they did find is that overall this tends to occur in the first 10 years of RA onset. I've always taught that ILD, as other extraarticular manifestations of RA, occur in patients with seropositive, bad disease, with long-standing disease. Well, this says they don't have to have really long-standing disease. It can occur within the first 10 years. The FDA has approved a new drug called Xamet, Xatmet. It's a oral methotrexate solution at a dose of 2.5 milligrams per ml, and it's being approved for patients with polyarticular JIA. It's out there, and it's the first of its kind, in fact. But I don't know about you. I'm sure this drug is going to be quite expensive, like all new methotrexates that have been repurposed for the marketplace. I've been using this for a long while, and basically you just get the parenteral solution that comes in a 2 ml vial or 25 ml vial, and you take the right amount, you squirt it into juice or water, and you drink it. It's 100% absorbed, up to 15 milligrams a week. And it's just like taking a pill, but it's dirt cheap and it can be drank. So, again, whether you want to buy the new expensive version or the old cheap version is up to you. What's the deal with rheumatoid arthritis and cardiovascular disease? Is it the RA? Is it the inflammation? Is it the test? Well, a recent study actually looked at a number of patients, not with RA, but just those who had SD segment elevation MIs, and they subsetted them according to whether they were ACPA positive or not. They found that patients who were ACPA positive, again, nobody here has rheumatoid arthritis, these are just SD segment elevated acute MIs, that they had a higher degree of mortality, a threefold higher degree of mortality, and a higher rate of reinfarction, 2.5-fold greater rate, if they were ACPA positive compared to those who were ACPA negative, suggesting that there may be something to the autoantibody, the CCP or ACPA positivity that says that there's something going on at a more basic level, at the vascular level, that may put these people at greater risk for poorer outcomes with myocardial infarction. Magnesium oxide for nocturnal cramps has actually been studied. I don't know if you've ever looked into this, and I have. There's very little data about why people get nocturnal cramps. There's a lot of myth and folklore and best advice from your mother-in-law that says that it's bananas and potassium and dehydration, and you should fix this by running to the refrigerator and squirting mustard in your mouth. Crazy things. But the fact is, no one really understands the pathophysiology of this or what really drives the risk. I firmly believe that dehydration can be a factor. I don't think there's no evidence that potassium is what will cure it. But there is some evidence out there. Maybe it could be magnesium. You remember in the old days, we actually used to use quinine sulfate over the counter with great success, but the FDA took that off the market suggesting that there may have been some cardiac risks associated with over-the-counter quinine use. Nonetheless, there's been this study of 94 patients showing that magnesium oxide really did not achieve better outcomes than placebo in preventing and treating those with nocturnal leg cramps. If you want to make yourself famous, go into the nocturnal leg cramp research business, and I think you'll do fine. I wrote down as just a thought this week that you should praise your patients for a few things: losing weight, stopping smoking, achieving remission that you measure and say, congratulations, ta-da, your CDAI or your DAS score is X, and that they should buy into that. Also their birthdays and important events, including important life events. Someone in Twitter actually said RheumNow is being kind of strict or hard in his demands, or, I thought it was sort of an odd statement, but I don't think I am being too demanding or of what we should do our patients. Remember, rheumatologists went into rheumatology because of the relationships with patients. And we need to foster that. And, to praise patients for these milestone and big achievements really helps the relationship quite a bit. A very interesting study answers the question about FM and ankylosing spondylitis. I personally can't imagine the overlap here, but there are some people who believe that there's a subset of those who have spondylitis or would-be spondylitis who in fact really have fibromyalgia. Well, a study of 99 fibromyalgia patients took a different look at this, and they actually MRI'd these patients, looking for evidence of inflammation and sacroiliac involvement in the FM patients. And what they did find was that 8% of patients met criteria for axial spondyloarthropathy, and that MRI sacroiliac, I'm sorry, that was 10%. 8% actually had evidence of MRI sacroiliitis. So I asked in the tweet, could ankylosing spondylitis be masquerading as FM? And a few people wrote back on Twitter that they thought it could. It may be something to consider in patients who meet the profile of spondylitis: young, inflammatory back pain. They may have other features, and maybe further investigation is warranted. Personally, I don't think I'll be doing MRIs to diagnose spondylitis in all my FM patients. The FDA has accepted the BLA application for the biologic sarilumab, an IL-6 inhibitor. This comes from Sanofi and Regeneron. They've accepted the application. The PDUFA action date for decision about whether this drug should be approved or not for moderate to severe active rheumatoid arthritis will come in late May. An interesting early arthritis study looked at what is the utility of an MRI in early arthritis patients, and what is the predictive value of doing MRI. And quite interestingly, they showed, number one, that 14% of their very large cohort, this comes from the Leiden, or was it the Leeds? So I think it was the Leeds early arthritis clinic, early undifferentiated arthritis clinic. 14% of patients developed rheumatoid arthritis. And they found that MRI evidence of tenosynovitis did have a significant predictive value for the development of RA, an odds ratio of 7.5. Not having MRI tenosynovitis had a negative predictive value of 95%, whereas having tenosynovitis by MRI had a positive predictive value of 25%, suggesting that in early arthritis population, maybe there is a role for doing early MRI. An interesting study comes from multiple groups, 5 groups, 4 in the United States, 1 in Italy, that looked at the disease that is seen in children called enthesitis-related arthritis. This is a subset of those older onset pauciarticular or oligoarticular patients who have spondylitis-related disease, but specifically looks at enthesitis. There are ILR criteria, and these 5 centers enrolled there are several hundreds of patients. I think it was over 400 patients. They showed that 78% of these children had a pauciarticular onset JIA, that 23% were ANA positive at the outset, and that SED rates and CRPs were not present in half. In fact, 46% for SED rates and 27% or so for CRPs. B27 was seen in a little bit more than half the patients. It was associated with being male, having higher active joint counts, sacroiliitis, and an older age at onset, meaning getting closer to 16 as opposed to being over the age of 9. So this group has characterized this population of ERA, enthesitis-related arthritis, may be useful for those of you who take care of children. Cassie Calabrese wrote an interesting article taken in the literature about the risk of venous thromboembolism in patients who have ANCA-associated vasculitis. A study of 4 different cohorts in 4 different European vasculitis studies looked at 417 patients and found 41 of them developing VTE, so about 10% risk of developing VTE. Half these people had GPA, the other half had micropolyangiitis and renal associated ANCA disease. And overall, the risk factors or the associations with VTE were seen in those with higher creatinine and those who had either skin or GI involvement, according to the BVAS, the Birmingham Vasculitis Activity Score. So those are the people who might be at risk, again, a 10% risk overall. And lastly, the FDA has recently approved abaloparatide. The trade name of this is going to be called Tymlos, Tymlos. It's only going to be approved, however, for high-risk postmenopausal osteoporosis patients, those who've had a prior fracture, those who had recurrent fractures, and those who are unable to take other existing osteoporosis preventative therapies. So this is a new anabolic agent that sounds a little bit like teriparatide, also known as Forteo, but this is the new one on the block. It's going to be also a daily sub-Q injection. It's also going to have the 2-year disease use restriction because it too has a dose-dependent risk of osteosarcoma. So there's a 2-year limit until they can study it further. It's been shown very well to prevent both vertebral and non-vertebral fractures and will be in a pharmacy near you by January, or actually I think they said June of 2017. That's it for Room Now. Be sure to go to look at our Twitter feed. We had a lot of big tweets and about over 100 tweets from last week's SOTA meeting, state-of-the-art meeting from the ACR in Chicago. A lot of them from great speakers, and I think you would find that to be a nice review. You can go to the Room Now website and find the citations for these reports. Tune in, register. We'll see you next week.